Have you been told you might need a knee replacement? Before you accept that as inevitable, there are 3 things I'm going to teach you that will help. Number 1, what exactly a knee replacement is in really simple, easy to understand terms. Number 2, how orthopedic knee surgeons like myself decide who might benefit from a knee replacement and who maybe wouldn't. And number 3, what you can do to make your chances of success with a knee replacement as high as possible. So hi, I'm Dr. Arjun Maldenia. I'm a consultant knee and hip surgeon. I work in London. I've been a doctor now for over 25 years and a consultant in the NHS and in private practice for now 10 years. I've treated thousands of patients with knee and hip problems, whether it's arthritis or injuries or tendon or muscle issues. I've been really lucky to learn a lot during that process and throughout my training. As an orthopedic surgeon, I think I'm in a really unique and fortunate position when I'm treating patients because I get a whole 360-degree view of them and what's wrong from meeting them, listening to patient stories, examining them with my own hands, organizing advanced scanning such as MRI scans or CT scans. Sometimes if non-surgical treatment hasn't worked, I then operate on these patients either with putting cameras into the knee or hip and fixing damage, or sometimes using larger incisions to repair damage, or sometimes to replace parts of the joint or all of the joint. And that gives me a real understanding of how the tissues actually work, why they may break down, how they're best repaired, and also it gives me a good understanding of how to look at scans and imaging as well, because I'm often looking at these structures inside the body. So this channel follows my OrthoLongevity approach. This is a biology first, surgery last approach that I follow myself, focused on keeping your joints strong and protected for as long as possible, so you'll be injury and pain free. Where necessary, we can offer surgery, but only as a last resort, and if we do, it will be using the latest proven techniques that are as minimally invasive as possible, using the latest technology and medical advances. If you stay with me until the end of this video, you'll have a really clear framework on deciding whether knee replacement surgery is the best thing or the correct option for you, given your specific situation. The usual medical disclaimer: this video is for educational purposes. It's not personalized medical advice, as I'm unfortunately not your doctor. Most people are told one of 2 things: that your knee is worn out, or there's bone-on-bone changes, meaning there are no other options except knee replacement, or you need to stop doing everything you enjoy. This can leave you with uncertainty, feelings of anxiousness or low mood. It's quite scary to be told you might need a knee replacement. Often patients will know people who have had knee replacements. Many do really well, but there are a good proportion, between 10 and 20% globally, who've had knee replacement surgery and haven't done really well or aren't happy with their knee replacement. And it can be quite a scary thought. Knee replacement surgery is also thought of as fairly painful to recover from, which can be true for sure. Certainly in the first 2 to 8 weeks, it can be really uncomfortable, and being told that you may need a new knee takes a lot of getting used to, basically. So what I've learned is most patients aren't really taught or understand the framework by which surgeons like us may decide that you may benefit from a knee replacement. So I'm going to walk you through how I think about it when I've got a patient in front of me, and you can decide how this may apply to you. So just a little bit of context about why I approach things a little bit differently in a more holistic manner. While I've performed many knee replacements and it's a very successful operation, it is a fairly brutal operation, and I don't feel it's changed significantly over the last 10 or 20 years. The knee replacement implants haven't improved too much since the 1970s. There are slightly different philosophies about how they're designed, and many of the designs work well. Some perform slightly better than others. We now have advanced technology like robotics to help us guide the implants in very accurately. And I'm someone that uses robotic surgery and has done since I've been a consultant. But having said that, many consultants who don't use robotic surgery have excellent techniques of guiding the implants in, so it's certainly not necessary. Robotic surgery also doesn't minimize the operation or make it a smaller operation. It potentially makes it a more precise operation, but the implants that you use, whether you're using robotic techniques or not, are essentially the same. And because of that, it's very difficult to prove that robotic surgery is better or worse or the same as conventional surgery using normal jigs. When you have knee replacement surgery, it's not really a replacement. The worn away surfaces on the ends of the 2 bones, the big bones that make up your knee. So that's the femur is here, this is the thigh bone. So very thin slices of the end of the bone are removed. They're normally about 8 to 10 millimeters thick. Then normally the top slice of the shin bone, so this is the top of the tibia bone, the shin bone, a thin slice is taken off that. That's normally again between 4 and 12 millimeters thickness, depending on how worn away the knee is and what type of implant the doctor is using. And then artificial parts, normally made out of a type of metal alloy, are stuck on the ends of the bones as replacement surfaces. And then normally is a thick, bouncy piece of plastic that's placed in between the two metal bits, and that acts as a type of cartilage or cushion. Some surgeons, myself included, though I didn't always used to do this, will take a little slice off the back of the patella or kneecap bone, because sometimes that's worn away. And if we do, we normally take about 8 or 9 millimeters off that surface. And again, we put a replacement part. Again, it's normally a piece of plastic. It's normally round or oval shaped. And then you have 3 surfaces that all meet on each other. And then we sew up the knee, and then it's done. The main issue is it can be often quite painful to recover from that. The knee's fairly sensitive. It's covered in nerves, and the knees often swell up and you have a lot of inflammation after surgery. So the healing process can take a long time. When I was training, consultants I worked for would tell patients it would take them 1 to 2 years to get better. I think we have tried to push things forward a bit, but I still say to most of my patients, for 3 months, they may be fairly unhappy with me and they may wonder why they had the surgery. But normally after 3 months, things start to get better and they realize their arthritic pain is gone, their knee's a lot straighter and more stable, and then they're normally happy. So it can be really, really good operation, but it does still have a fairly high rate of dissatisfaction or happiness. And some people do have stiffness with their knee replacements, persistent swelling, or just ache and pain, and it doesn't always feel right because the implants are not as clever as your human knee. And because of that, 10 to 20% of patients, depending on which studies you read and depending on which country you're in, often maybe wish they hadn't had the procedure. And that's really different to something else that I do commonly, hip replacement surgery, regardless of how it's done. And there are many anatomical approaches to get into the hip, like the anterior approach, which is through the front, the Rottinger approach, which I do, which is just a little bit to the side of the front. Some doctors going through the side, that's called the lateral or Hardinger approach. And most doctors, and I do this as well, going through the back or the posterior approach. All these approaches are different, but yet patients who have surgery throughout all these approaches do really, really well. And the 95 or 97% of patients who have a hip replacement are really happy and often really quickly within about 2 to 6 weeks. So replacement surgery can be different depending on the body part, and knee replacement surgery, certainly total knee replacement surgery, which is what we're talking about today, not partial knee replacement surgery, which is something I'll talk about in a later video. Total knee replacement surgery is fairly big surgery and can be very difficult to get through. And that's why as a patient, you've got to be really motivated. You've got to be really on board with your surgeon and really trust them. And you've got to have a good relationship and dynamic, especially to get through any hard or difficult times. But you also need to see your physical therapist and get in the gym, get that leg strong, get those muscles working, and that's going to help your recovery. In fact, the more you can do before surgery to get fit, to get light, to have a really good diet, to get on board loads of protein, the faster you're going to get through your surgery afterwards. So there's a lot to be said for really good prehabilitation. Okay, so let's start with the basics. What is knee arthritis and why does it cause pain? So knee osteoarthritis essentially means that the very thin protective lining of cartilage that is stuck on the end of each of your long bones is starting to get damaged or thinned or softened or cracked or broken or worn away. And the cartilage on this model, it's not colored differently, unhelpfully, but it's the tissue just on the end here. And it's normally about 2 to 3 millimeters thick, though it's about 7 millimeters thick on the patella because the kneecap has the thickest articular cartilage in the body. So osteoarthritis is when that cartilage layer is getting thin and damaged. And what's happening is the bone underneath, which is very sensitive, is getting exposed to increased stress and load. And actually a lot of the pain is from nerve endings in the bone that are being stimulated. It's not really from the cartilage. Cartilage actually doesn't have any blood supply or nerve supply. And so when you have cartilage tears and that damage, it doesn't normally directly cause you pain. The pain is from inflammation in the knee because knees behave really well if the bits moving part on top of each other are smooth and there's no friction. When you have friction or there's loose pieces or bits that are hanging off, that stimulates cells in your knees lining, or the inner skin of your knee called the synovium, stimulates those cells to be triggered and to be on alert, and they release lots of proteins and chemicals that make your knee start to swell. It makes it very sensitive to pain, and all these toxins come into your knee that kind of cascade and give you like a vicious cycle. So they stimulate even more proteins to be made that can kind of damage cartilage. They can make the blood vessels around the knee leak more, so you get more swelling. And all of these things stimulate pain signals, so you feel more pain. And on it goes. So normally the pain from cartilage damage is because of exposed bone that's very sensitive, and extra load is going through the joint because the cushioning of the cartilage, and also the meniscus tissue, which is another rubbery structure that's sort of wedged in between the bones in your knee. Because the meniscus tissue is disintegrating and getting torn, the cartilage stuck in the end of the bones is sometimes wearing thin. You start to get this inflammatory process, and that's the thing that's really hurting you. It's not the cartilage tear itself. And this is really important. And it's important because patients don't always act like their X-rays or MRI scans. So by that, I mean some patients can have fairly worn out knees, not much articular cartilage on the end of the bones, but they feel okay. You know, the knee's not too bad. It's a bit stiff, aches a little bit. Maybe it's a little bit misshapen. They're getting a little bit bow-legged or knock-kneed, but they function really well. Other patients have much less cartilage damage, but they feel it really badly in the knee. They're in agony. They want something doing. And that's normally because how their body makes and handles inflammation is different to the person who's not feeling it. So a lot of it is to do with inflammation, and it's not necessarily to do with how much cartilage is missing or whether you've got bone-on-bone changes. So don't worry about that, it's more complex. In terms of inflammation and why you feel pain, so many things affect inflammation. So not having cartilage is definitely one of them. Being really heavy is another. So if you're carrying a lot of weight, a lot more weight goes through your knee joints, and that pressure can really hurt your knee. Also, having minimal muscle or low muscle mass in your body is a really important factor that can make your knee feel worse. But if you reverse it and get in the gym and do your strength training exercises like the ones in the videos that I've made earlier, so see my channel and watch those videos. If you get your muscles strong, and it doesn't matter what age you are, whether you're a woman or you're a man, all of us have got the same muscles in our body. As long as we've got all four limbs and we haven't had any neurological issues, we've all got the same muscles that work. And if you get in the gym and start moving those muscles, moving your legs against resistance, ideally in a gym with machines where you can adjust the weight so they can be reasonably heavy for you, then you can do exercises that I talk about in another video, such as leg press or calf raises or hip abduction. All of these movements against resistance will help your muscle tissue grow a couple of days afterwards, so you come back stronger. So having strong muscle really reduces inflammation in your knee. Having a good diet is really important. You may have heard of things like your gut microbiome, and that's because what you eat affects the bacteria in your gut that's there to protect you, and also what you eat can directly or indirectly lead to more inflammation, bloating, pain around your body and your joints. Foods that can really help reduce inflammation would be things like berries, dark green vegetables, oily fish, nuts, seeds, really good extra virgin olive oil, legumes, pulses, lean proteins. So generally really healthy foods. They can help. So what you consume is important. How we sleep is really important. So I didn't sleep much last night. For some reason, I was on my phone really late. So today I was quite tired. I still got to the gym, but that lack of sleep would have increased my cortisol levels slightly, increased my inflammation. My performance in the gym today probably wasn't quite as good as it would have been if I'd actually gone to bed on time. So not sleeping well for whatever reason, whether you're stressed out or you're anxious, your mind's busy, or like me, you're on your phone, that really affects inflammation and can indirectly affect like your knee pain. Other things that can affect are genetic factors. Sometimes it may be that in our genes, or you may know in your family, your parents or uncles and aunties or brothers and sisters do struggle with knee issues, and a bit like sometimes high blood pressure or being at risk of having diabetes, maybe in the family. Sometimes people also can be at risk of developing knee osteoarthritis and knee pain just because it's how it is. It doesn't mean there aren't things you can't do to reduce that risk, but you may have a little bit more risk than your neighbor who's got a different set of genes to you. Other things that can affect knee osteoarthritis and whether you'll get it is trauma or surgery. If you've had to have lots of surgery, especially years ago, when sometimes the techniques weren't quite as good as they are now, you could have had minor damage during the surgery where the surgeons were trying to help you, but accidentally sometimes minor damage or scuffing of the cartilage may have happened with their instruments. Sometimes that can lead to early arthritis, but more so having significant trauma to your knee or fractures to your knee can definitely increase your risk of arthritis or significant ligament injuries like anterior cruciate ligament injuries. So what happens in osteoarthritis commonly? You may get stiffness. Stiffness is normally due to inflammation where the tissues get thicker and tighter. It's very difficult to move them. Often the stiffness can be there first thing in the morning, but as you get to warm up the joint and start moving, things get better. Often again, weather sometimes can help. So if you're in a hot and humid climate, it may affect you less than if you're where we are in London, which can be sometimes fairly damp and grey, especially at this time of year. It's February now, and sometimes that can really affect people's joints. You can also get swelling in your joints, and as mentioned before, that's normally an inflammatory reaction again, where your body is trying to help by making more fluid in the joint to lubricate, but unfortunately the fluid is too much and it has chemicals in it that are inflammatory chemicals that cause pain, often can cause further damage to the tissues in the knee and often recruit more cells to keep that process going. So inflammation, though initially inflammation is there for healing, when you have inflammation in knee arthritis, it's often chronic inflammation or long-term low-level inflammation as opposed to short-term acute inflammation. Short-term acute inflammation is a good thing. It's what you need when you're trying to heal from a broken bone or from a cut. But long-term chronic inflammation is not good. Inflammation is a bit like a thermostat. If your thermostat's always on all the time, it's not a good thing and you can get changes that happen in your body. What you want is for the heating to be off and just turned on a little bit high when you have an injury and then turned off again. But chronic inflammation that some people have with various diseases such as osteoarthritis or even diabetes, that's not good for the body. Your knee can sometimes start to get a bit deformed. You may notice that if you have osteoarthritis or you know friends that do, their knee may become a bit bow-legged, like an old-fashioned cowboy. We call that varus. That's V-A-R-U-S. That's what that shape means. It could also go the opposite way and you could become knock-kneed. That's called valgus. And those patterns are based on how you load your knee, normally how your posture is and the shape of your skeleton and how you walk. And again, some of that is predetermined by genetics and some of it is how you carry yourself and how you have carried yourself over the years in terms of how you walk, run, stand. You can get what we call crepitus or cracking or a crunchy kneecap noise. That's often, again, bits of bone sometimes either rubbing or grinding on each other because the cartilage has worn away, or sometimes it's bits of soft tissue moving on each other like cartilage, or folds of synovium, which is the inner lining of your knee, moving or flicking on each other. And it's not anything you need to be worried about, but it certainly can be troublesome if it's painful. More often than not though, it just doesn't sound very nice, but it's not painful and it's nothing to worry about. You can get pain away from your knee when you've got knee osteoarthritis. It could be that you feel the pain high up in the hip, which can confuse you and sometimes can confuse the doctors or clinicians that are treating you, but often pain a little bit higher or lower than the knee in your muscles, like your hamstring muscles or in your calf or in your shin, is normal because of how nerve fibers are connected around the knee. You get something called referred pain. You sometimes feel pain away from the site where the problem is, or it can be due to muscles that are nearby and tendons that are very long structures, and lots of the muscles around your knee, like your quadriceps muscles or your hamstrings muscles or your calf muscles, they often span and cross the knee joint. So if there's a problem in the knee and they're nearby and they get inflamed or they get tight or slightly underused and weak, then the pain can be felt in the entire length of the muscle, and you often can feel it further away as opposed to near the knee. So some people are not able to fully straighten their knee if they've got quite bad knee osteoarthritis, and we call that a fixed flexion deformity, which means the knee's held sort of slightly bent, it doesn't straighten. That's again very common with fairly advanced osteoarthritis, and it's quite a good sign that if you've got lots of pain as well, you may benefit from a total knee replacement. Often you can't straighten the knee because the tissues at the back, called the capsule, so it's the hard tissue that kind of helps stick the bones together, the joint capsule, that normally gets quite tight and shriveled up and fibrotic, and it kind of forces the knee to bend a bit. And then the muscles at the back of your thigh, your hamstring muscles, also start to get tight. And that's why it's really important, if you're getting knee osteoarthritis or if you've got it, you do your best to try and reverse this process or to stop it progressing by getting in that gym or seeing a physio or a personal trainer, or ideally even a strength and conditioning coach if you can find one, and start stretching out your legs, your hips, your knees, your calves, and start to strengthen the muscles. You want to stretch out the tendon and the muscle and strengthen them. And it's never too late to start this. If you're really struggling with pain and pain stopping you, you can consider either taking pain medication like Nurofen or ibuprofen. If you're allowed to take anti-inflammatory medication, you can try ice packs or heat packs, depending on which one works for you. Both can be really good depending on the circumstance. Ice is better if you've got a hot, swollen knee, it will cool it down. Heat packs or hot water bottles are better if you've got a cold, stiff knee that needs to move. You could consider injection therapy. There are a number of injections you can have in your knee. And again, I've covered injections in another video on my channel. So please watch that to understand more about injections. But various injections in the end can help with pain and swelling and stiffness, either temporarily or hopefully for the longer term. You can take injections, and then when your knee feels better, get in that gym again, get those muscles stretched, get those tendons stretched, get those muscles strong, get the movement back in your joints so you can get your independence back, and maybe even avoid surgery. Or if you need the surgery, you're going to do really well because you're in fantastic condition. So what you want to do is work with your medical team, with your surgeon, your anaesthetist, your physio, your personal trainer, and get in the best shape you can so you can help them to help you. So let's just talk about diagnostics and testing for knee replacement. Your surgeon, of course, will know this, but ideally, just so you know, you need to have x-rays. X-rays are really good at showing the bone. They absolutely do not show you the cartilage or the meniscus. So you may think that they're useless, but they're not. They're really useful because they're cheap to perform. That's the first thing. And they tell us about the shape of the bones and the alignment, and they need to be with you standing up. So weight's going through the knee. If weight's going through the knee, the gap between the bones will reduce or may even be so diminished that the bones are touching or bone on bone. And that's because that infers the cartilage has disappeared. So x-rays are a really good test. I use them all the time, but I would say that you need 3 to 4 views of x-rays, one from the front of the knee, one from the side, and ideally one from the top, looking at the angle and the joint between the femur bone and the patella bone. Very important. Some doctors also get a 4th x-ray where the knee from the front, instead of being straight, it's very slightly bent. That's because that x-ray view will show us the posterior or the back part of the femur. I personally don't use that x-ray, but lots of surgeons do. I do insist on another type of x-ray, which is called long leg alignment views. That's where a patient is standing and we take a full x-ray of the lower half of their body, from the pelvis, hips, femurs, knees, tibia, ankles of them standing. And then I can see the alignment, whether you've got a neutral straight alignment, whether you're valgus, which is knock-kneed, or whether you're varus, which is bow-legged. And that really helped me plan the surgery with the robotic technology that I use. I also ensure that the x-rays are taken with a scaling marker or a scaling tool. I find that's really important because I use computer software or digital templating to plan all my joint replacement surgery, whether it's total knee replacement, partial knee replacement, or hip replacement surgery. The software means I can overlay implants from different companies depending on which implant we've agreed to use for you, and I can see which size and shaped implant will actually fit your anatomy. To know the correct size, it's important that we understand the magnification of the x-rays so we know how the x-rays relate to you, because the x-rays taken are normally not life size. So when you're having x-rays, you should notice that you're having some kind of ball or marker placed near you, or sometimes for hip x-rays, there's a special plate that you can lie on and a special belt that you can wear. And these markers show up on the x-ray, and you can ask to look at those with your healthcare provider. Another type of imaging that can be got, which I sometimes get, especially if I'm trying to figure out if I need to replace just part of the knee, which is called partial knee replacement, or all of the knee joint, is an MRI scan. And an MRI scan, of course, as you may know, has the advantage of showing us the soft structures in the knee, such as the meniscus tissue, the ligaments that hold the bones together, the tendons that attach bone to muscle, and also the cartilage that's so important. We can see where the cartilage is, where it's maybe thinned or worn away, where it's totally absent. So how do I decide whether you might benefit from a knee replacement? Here are the 5 things that I look at. Number 1, and the most important thing, is what are your symptoms and are you miserable? So if you're having lots of pain, stiffness and swelling, and it's getting you down and you have more bad days than good, and we've really tried non-surgical measures like strength training, injection therapy, optimizing your nutrition, getting your weight down, helping with sleep and stress, and you're just fed up, it's time for surgery. Number 2, do you want the surgery? That's the most important thing. It's really difficult for me to operate on patients unless they want the surgery. It's not normally my job to tell you that you need surgery because I'm not having the surgery, I'm just doing it. It's much easier to do it than have it done on you. So it needs to be a joint decision and you need to be driving that. If you're fed up and you want it, then that's a good sign. Number 3, are you medically fit enough to have the surgery? So for me, it's not an age thing at all. Some people worry that they're too young or too old to have surgery. Ideally, we don't want to replace joints in young people, but sometimes we have to. If your joint's destroyed and there's no other option and your quality of life is awful and you want to get back to life with your family and your friends, you've got to have your joint replaced, and we'll deal with the consequences afterwards. Joint replacements do last so much longer than they used to. We were taught 10 years was great when I was learning, but now we often aim for 25 years, 35 years, 40 years. And that's because our techniques are so much better and the implant materials definitely are a lot better, though maybe the implant designs aren't a lot better. So if you're medically well, regardless of your age, and you've got good heart and lungs and you're fit enough and you don't have much in the way of chronic diseases that can increase your risk of a complication like diabetes or lung disease or liver disease, then it's good for you to proceed. Number 4, do you have a high BMI? Are you really heavy? If you're carrying a huge amount of excess weight, it's really difficult to do the surgery well, quickly with smaller incisions and to give you a good outcome. So there's great studies that show that patients with a really high BMI do really well compared to patients with normal weights and BMIs. So BMI, just if you're not sure, is a really rough measurement, probably not that good anymore, but it's where we get your weight in kilograms and divide it by your height in meters squared. So for me, my weight is 83 kilos at the moment and my height in 1.79 meters. So it would be 83 over 1.79 squared, and that equals 25.9. Ideally, you want to be 25 or below. So because I'm 25.9, I'm okay with, because my BMI was a lot higher about 7 months ago and I'm losing weight and getting fitter. So I've got a little bit of work to go, but I'm almost there. If your BMI, as a rough rule of thumb, is 40 or over or 50 or over, you're significantly overweight and it's really high risk to do the surgery. And I would say, though it's not a popular opinion, I would say you shouldn't have the surgery right now. You need to address that weight and bring your weight down. And that can be by any means necessary. Of course, diet and exercise would be the best. Some people have surgical options. Other patients of mine now are having their newer GLP-1 inhibitors, which seem to be working in terms of weight loss. I'm not really an expert in how safe or good they are in the long term, but they definitely seem to work while patients are on it to lose weight. So if you can bring your weight down, and it doesn't have to be back to normal, you don't need a BMI of 25 or lower, but I think if it's at least lower than 40, that will really help. It'll help us help you do the operation quickly, safely, less blood loss, more likely that we'll put the implants in the correct position, less likely you're going to have other complications like blood clots, infections, malalignment, fractures. So that would be the 4th thing that we look at. The 5th important thing I look at is who's around you. Have you got a safe home to go back to? Do you have people to help and look after you while you're recovering? Or are you looking after people? Are you a carer? So your social situation is super important. It may be that, 5 patients all have the same x-ray, and even medically you're all the same. Maybe you've all just got some diabetes or you've got to take tablets and a little bit of blood pressure, but you all live in different situations. So one person might have lots of family there. One person may be homeless. One person may have to look after a son who's an adult son but has disabilities. And another person may have 10 cats that all need looking after. So all these social factors are really important. They will affect how we plan the surgery, what's going to happen to you before and after, when you can go home, if there's any amendments or help that needs organising at your house, whether that's various, changes to the bathtub or the toilet seat, ways for you to get up and down the stairs if you live in a flat and there's no lift, whether or not you need carers to come in. So social factors are really important, as are medical factors. It's not just about the knee, and it's really important that we think holistically as your practitioner. So before we finish, here's a checklist for you to ask yourself, and this will help you decide whether or not you need a knee replacement. Number 1, are you sleeping through the night, or is pain waking you up from your sleep? If the answer is yes, that's a really important question to answer, and yes normally means you may need a knee replacement. How far can you walk on a typical day, either in terms of distance or minutes? If you find it really difficult to walk without always having to stop or sit down, or that you always need a stick, then you may want to consider having a knee replacement. Have you done at least 12 weeks or 3 months of strength training in the gym? If you haven't been able to do that, but you technically could do it, but you just haven't done it because either you don't know how, or it's difficult for you to access, or you don't feel confident, or you don't know what to do, then you should do it. You should do that before you have knee replacement surgery. A, because your symptoms may start to improve a bit, such that you can put the surgery off or try other options. If you get fit and strong for your surgery, you're just going to do better. Have you tried to improve the load going through the knee? So can you use a walking aid if you want to? Lots of people don't want to use a stick, but sometimes that can help. Have you tried a knee brace or a knee support? Sometimes knee supports can really help because they can slightly straighten the leg or make it feel more supported. Have you optimized your weight, which is essentially the load going through your knee? Have you reduced weight? Number 5, are you having lots of inflammation, and have we done things to help reduce the inflammation? Have we altered your diet so it's anti-inflammatory? Have we reduced your sleep and your stress and improved your sleep quality? Have you tried anti-inflammatory medication to help? Have you tried ice to help reduce swelling? Have you tried anti-inflammatory injections like platelet-rich plasma or corticosteroid? 6, do you have a deformity in your knee that's worsening? Sometimes if you're getting more bow-legged or more knock-kneed, not only may that look affect you and you may think that you want a straighter leg, but more importantly, structurally, your knee may not be as stable as it used to be. You may have instability that's getting worse and worse. If that's true, you may need a knee replacement. 7, has your knee made you avoid things in life, stop you going to see friends and family? Is it keeping you indoors? Is it making you miserable? If that's the case, I would say that's a strong reason to consider having knee replacement surgery. 8, what's your goal? Is it just independence? Is it to travel? Is it to do sport? Whatever the answer, have a think about why do you want this knee replacement, or how is the osteoarthritis affecting you? What are you missing out on? If you're missing out on some things, but you've adapted, so you can't play football anymore, but you don't mind because you've taken up golf, you probably don't need a knee replacement. But if you're missing out on things and your goal is to do those things again, then you may need the surgery. Number 9, if you have the surgery, what does a good outcome look like? You need to be realistic. You need to talk to your surgeon. It may be that if you're a professional kickboxer, it may be that you may not be able to get back to that. It may be difficult to get back to that. It may be that if you need to kneel a lot, either for religious reasons or for your job because you're a plumber, it may sometimes be difficult to do that. So you need to understand what a good recovery looks like and what the likely chances are, and does that match what you want? If it's difficult for a knee replacement to get you there, it may be that a knee replacement is not suitable for you, or you may have to temper your expectations so they're realistic. Normally, knee replacement will give you a really straight, stable knee that doesn't hurt anymore. 10, and lastly, if you delay knee surgery, which is totally fine, it's always good to delay or defer surgery. There's never normally a bad outcome if you do that. What's your 3-month plan to help you improve? What can you improve on from everything we've discussed? So thanks for listening. As a surgeon, I'm really comfortable operating and I do it each week, but if I can help you avoid surgery with all the other treatments we have, especially the holistic treatments that treat your entire being, not just your knee, then that's what we're here to help with. My goal is to help you hurt less, move better, and stay active and independent for decades, and for you to be in the best shape of your life regardless of what age you're in. So thanks so much for watching. I hope this was helpful. I'll see you in the next video.